On. Good morning, good afternoon, good evening. I'm Christine Hancock from C3 Collaborating for Health, and delighted to welcome you to our international seminar, which is virtual, which makes it so much easier to welcome this really exciting and interesting team from New Zealand who work with the Pacific communities. So a long way away from our point of view, but also a big difference in time. So we're really grateful to them for either delaying their evening entertainment or breaking off in the middle. C3 is a small public health charity headquartered in London, but working globally. And our international seminars, which we've been doing almost since we began about 11 years ago, are a way for us and for our colleagues and our network to hear some of the interesting work that's going on in other countries, because it's interesting to learn and to hear about, but also hopefully because it triggers and stimulates ideas for people working in the UK and elsewhere who are listening today. We're about preventing chronic disease, and we really work at the major risk factors. And that is absolutely what our guests today are involved in. And we're really interested in hearing you. We're grateful to our sponsors, Cancer Research UK and the Burdett Trust for Nursing. And I'm going to hand over now to the Pacific Heartbeat team. I'm not going to introduce them each individually, but as they speak, I think they'll tell you about themselves and about their work. And Collin, really grateful that you and your colleagues are here. So hand over to you, and we're looking forward to hearing your words and looking at your slides. Slides and a recording will be available afterwards. Please put questions and comments in the chat, and whatever time is left at the end, we'll be able to have some further discussion. But Collin, to you and your team, and I do apologize. I think we've managed some of your Pacific names, but we've regularly, I think, lost an L of your name, Collin, but it's just reappeared, I see. So thank you for your tolerance, and over to you.
Well, good evening from our end of the world. It's a real pleasure to join you all. I realize it's early, it's in the morning at your end. I'm pleased to join you with my colleagues Maria and Leo. They will introduce themselves when they present, but I'll start off our trio presentation. I'm a public health physician, and I am the chief advisor for Pacific programs at the National Heart Foundation. My day job is with the University of Auckland, and I'm an associate professor there in public health. What I thought I might use my short time is to just give you an overview of the situation here in New Zealand, and my friends will tell you more about Heartbeat itself. I was actually one of the people that founded Heartbeat all those years ago, so that should give you some indication of how old I am. I think I've been involved in this for a little while. So let me just, hopefully this works. The share slide arrangement. Can you see my slides?
Yes.
Yeah.
You just need to maybe put it on slideshow.
Yeah. Okay. Yeah. So, so in the time that I have, I'll just talk a little bit about the background, and then more specifically about the non-communicable diseases and risk factors. The big bogey for us in New Zealand is really equity. How do you ensure that everyone gets a fair suck out of the salve, as we say down under? We have, and then and then of course it'll lead on to my colleagues talking more about Pacific Heartbeat. I mean, we're a small nation. I showed this because it's important to just give you a context. So New Zealand, 4.7 million, about 500,000 Pacific. We also have a large Asian population, and of course the indigenous Māori. It's important to point out that when we say Pacific communities, there are actually several. There are many, originally from the small islands in the Pacific region who've come over to New Zealand mainly for work. New Zealand did well in the 50s, 60s and 70s, and they needed the labor, and our families needed the work. So it was a happy match. Since then, of course, things have changed, and generally Pacific people in New Zealand are at the bottom end of the socioeconomic spectrum, and as a consequence have poorer outcomes compared to other New Zealanders, along with the indigenous Māori. Both the Pacific people and Māori have not such great health outcomes in general, including heart disease. We have a very good health system for the amount of money that we spend. We have a very good health system for most of our citizens, for most of the services. It's funded mainly by the general tax and a small private sector. The issue, of course, is equity, as I've made mention to you. Generally, for indigenous people and Pacific people, they have the most difficulty accessing healthcare. Generally, the quality of care received is not good, and there are, frequent and fairly common complaints about bias and racism in the health system, and ongoing challenges with the workforce. As a consequence, just recently, within the last month, the government has announced significant reform of the health system in response to what we call postcode healthcare. What you get in New Zealand depends on where you live. By that I mean, if you have a heart problem and you lived in the southern parts of this town, you generally didn't get as good a service if you lived in the central part of the city. So we're about to embark on a fairly significant reform of the health system. This is just to show you life expectancy at birth, significant differences for both men and women, for Māori and for Pacific people compared with other New Zealanders. And that gives you some indication of the kinds of challenges that we face as a nation. We do health surveys on a fairly regular basis. Interesting to note that most adults, including Māori and Pacific people, report that they're in good health. NCDs is the major cause of death, disease and disability in our nation. Half of those deaths are due to heart disease. It is declining in all ethnic groups, not declining as fast enough for Pacific people, but declining nonetheless. Obesity is a major problem, a major underlying cause of many of the chronic diseases that we see, and Pacific people in particular. About 2/3 of the adult population are regarded as obese, and there's quite a share who are overweight. So in fact, close on 100%, 90% are either overweight or obese. And there's a little bit of light at the end of the tunnel. There was a recent study from here in Auckland, in New Zealand, showing that there's possibly a decline in obesity levels in 4-year-old children of existing data. But older children, 5 to 15, it's still growing. This is a graph of the incidence of rheumatic fever. As you know, rheumatic fever is the canary in the mine. It really signals how things are. And, you know, for a wealthy country like New Zealand, this is a shame on us that, as you can see here, the incidence of rheumatic fever in European kids is negligible, but significantly higher among indigenous Māori and particularly Pacific children between the ages of 5 and 14. So this is, I think, an excellent illustration of the problem of equity that I spoke to you about in the beginning. And despite our best efforts, we haven't really been able to do anything much about the incidence of rheumatic fever in this country. So this is a graph going back to 2009. As you can see, it's chugging along and the gaps are not closing at all. So I think this graph of rheumatic fever tells you a big story about what happens to us here in New Zealand. Smoking, as many of you would know, is probably the most significant preventable cause of NCDs. And adult Pacific people continue to smoke at twice the rate of the rest of New Zealand. Smoking prevalence hasn't declined in Pacific folk since 2011, 2012. So it continues along at about 23-24% of the adult population. And sadly for us, there is no existing effective program targeting Pacific people. And this is one of the things that we are continuing to lobby our political leaders to put attention to smoking. As you know, smoking is a major cause of heart disease. And, you know, there's no hope in to see any decline just by addressing physical activity and nutrition and all of those things when smoking is the way it is. We have a goal in this country of, it's called Smoke-Free New Zealand 2025. But I keep saying to people that's a pipe dream unless we dedicate some serious effort and resources to reducing smoking amongst the adult Pacific population. By the way, as you can see in this slide, indigenous Māori are worse off than Pacific adults. Declining, of course, but nowhere near the rate that we wish. On the upside, daily smoking in young people is low, and one would hope that this pattern continues on, and that we do support and encourage a smoke-free generation in New Zealand. So this is from the Youth Survey of 2019. As I say, the issue for us is actually equity. How do we reduce unnecessary, avoidable, and unfair differences in a range of issues, including heart disease? So equity is the big challenge for us. Some of you would know this. Hart's law was coined in 1971, which basically says those who need it the most get it the least. And that's a story that's told and retold many times over for many conditions in New Zealand. Fortunately, we have a government at the moment that's sympathetic to the issue of equity, and particularly Indigenous Māori health, and to some extent, the health of Pacific people. But, you know, despite the best efforts, including significant investment by governments, we continue to have major inequities in housing, in educational achievement, in jobs, in income. All of those things that you know are really important in determining good or bad health. So this is why I raised the issue of equity, because It's receiving quite a lot of attention at the present time with our government, but it is stubborn in many respects. And the work that the team does at Heartbeat is dedicated and directed at addressing those specific issues within the Pacific communities. So I've already spoken about many of these differences in life expectancy at birth, mortality differences. It begins in early childhood, and pretty much whatever you look at in the respect of the determinants of health, the differences and inequities are there, as I mentioned. As I say, I was probably inadvertently told you how old I am. This is a paper we published in 1990 when I was a registrar training in public health that really pointed out the differences in heart disease mortality for Pacific people compared with other New Zealanders. And in you have these slides and you can look at it at your leisure. But we knew back then the ethnic differences that exist in our country, and in we also looked at cabbages or cardiac interventions, which showed that despite the higher prevalence of heart disease and higher mortality from heart disease among Maori and Pacific people, in fact, they were less likely to get a cabbage, to get a revascularization procedure. And sadly, my friends who continue to study these issues in New Zealand telling me that it's pretty much still the same. In other words, it's hard to know why it's challenging to continue to see these differences that exist in our country. So there's a lot of work underway to try to reduce inequities in health. We've just announced a reform that I spoke about, and also the government has signaled its intention to develop a strategy with a policy dedicated to improving the health of Pacific people in New Zealand. A number of these things would appear there. So, sorry, I've gone on a bit. Just to give you an overview of what things are like. So inequity or differences in health outcomes is the major challenge we have, particularly Pacific people. It's pervasive, it's indolent is another word that I would use. And it really begins with the broader determinants, such as inequities in access to housing and quality of housing, in income, in education. Those are the things that really determine the specific concerns, such as heart disease. Every reason to be optimistic. We have a government that's sensitive to the issues of inequities, and they're making headway in trying to address these differences in housing and education and in health. And as I say, I think support for specific programs such as Heartbeat, of course, we are hopeful that they'll help to make the difference that we want to see. So I'll stop there. Thank you very much.
Collin, thank you. And while Leo is while we're ending your slideshow and bringing on the next one, you've really well brought out so many of the similarities and how much we can learn from the work your colleagues have been doing, the whole question of equity, the ethnicity differences, and what you call postcode healthcare. We've tended to use the slightly more flippant phrase of postcode lottery. So really lots of similarities. So delighted to move on now to Leo to move the story on. Over to you, Leo.
Thank you very much. Talofa lava, everyone. My name is Tutuila Leo Va'auli. And like Collin alluded to, many different Pacific people from Pacific Islands here in Aotearoa. And I'm from one of those islands from Samoa, born in Aotearoa, raised here. And before I kick off our slides, I work as the community liaison lead for the Pacific Heartbeat team, which I'll go through in a minute. So in my role, I serve the team with engaging with different organizations at workforce level and community level. So that's a big part of my job, is advocating for our team to Pasifika throughout Aotearoa. Okie dokie, here we go. Let me get this going. Cool. Now, of course, there is a team. As Colin mentioned, we are Pacific Heartbeat. It was a team that was formed in 1991. And there's our team there at the top. As you can see, it says meet the team, and just above that is Colin. So Colin's so special, his photo isn't there yet. So
yeah, I was going to say, Leo, where's my? Am I not part of the team?
You're in the heavens. You're in the heavens, Colin. So looking after our team, as you know, we've got our advisor, who's Dr. Colin, and then underneath that is us. We've got Branko there, who's our prevention manager. Takui, who's one of the trainers there. Myself, Sue Pirrett, who's another nutritionist, and then Maria Bernard, who will be on, and then Alex Nicholas, and then Ashley and Jill. So those are some of the faces of our team. Now, moving on. Okay, what is Pacific Heartbeat? We were established in 1991. Thank you to Colin's vision and a few other Pacifica leaders back in their time. They realized that they needed to, as Colin talked about, we needed to do something. So it was established, and the focus on health needs of our population, our growing population in Aotearoa, New Zealand. And what our work is, encouraging our people to eat well, being smoke-free, and being more active. Now, Pacific Heartbeat, we actually deliver food and nutrition and cooking courses. So we've got a number of courses that we deliver, which I'll go through. And our next speaker will also talk in detail about the two bottom ones there. So we've got a course which is the AUT Certificate of Proficiency in Pacific Nutrition, or CPPN, Workforce Nutrition course, WNC, Community Nutrition course, and then the cooking course. So we've got a few acronyms there for our courses. Now the first one, just a bit of a breakdown on this course, the first course, which is it does have credits here in New Zealand, and in our system we do have an education system. We do have a course which is, it's AUT, so it's a university accredited course, and there is a bit of a cost, but it's heavily subsidized by the Ministry of Health. And the unique thing about it is it's delivered over 6 evenings. It says Tuesday in there, but sometimes it's delivered on different nights, 5 to 9 p.m. So that one there, that's actually when it was delivered face-to-face. But now, due to COVID, we've had to sort of adapt, and we deliver it also online. So it's either a combination. It's either face-to-face or online. Currently, we've just finished delivering our CPPN, online, and then our next one, we're looking to go online as well. The great thing about being able to deliver online, is I'm sure you all know, is you can reach the masses. So we're able to reach our different Pasifika populations all over New Zealand, not just in the big main centres where they predominantly are. The target group. So there is a target group for those working with our Pasifika or Pacific communities, and it is able to train, advise, and support others in making healthy food choices. Okay, and it's like it says, interactive, hands-on, and online support and assessments. There's a few outcomes of the courses, what we try and achieve. The one thing we've found is there's nothing beats face-to-face. as I'm sure you're all aware, having that face-to-face contact, nothing beats it. But unfortunately, due to these times, we've had to go online. So just some of the goals, or what we tried to outcomes, is to increase knowledge and skills about nutrition, physical activity from a Pasifika perspective. So this course is based at looking at things from a Pacific lens, and looking at some of the difficulties that Pacific people face here in Aotearoa, the plentiful supply of food. Also, participants have increased knowledge and skills about shifting mindset of our Pacific people. So that's the one of the barriers, is getting our Pacific people here in Aotearoa to change their way of think a bit smarter. And some of the other points there. Probably that last one, participants to improve their cultural appropriateness of the service they deliver to Pacific people. The one thing we do have is we do have non-Pacific people that work with Pacific. So at the same time, a big thing about this course is trying to look around the appropriateness and how to work with our people here in Aotearoa. The next course that we have is the WNC, or the Workforce Nutrition course. Now this course here is looking at those, it says workforce, so it can be anyone that works in a non-government or government setting. Okay, and it's those that, like it says there, in health, education, or other workforces who want to upskill their knowledge in regards to nutrition and how to work with Pacific communities. So that's our target audience. And with this course, there's a few different options that we do offer our workforce. It can be around general nutrition, the Pacific cultural engagement and nutrition and weight control, facilitation, the Pacific way, and then there's specific topics which our trainers and nutritionists can talk about, e.g. diabetes, heart disease and stroke, and then also the different life stages of nutrition. So what we've found is that this course here has been really one that a lot of those that work in the workforce, it's one that they really enjoy. We've done work with the New Zealand Police and different government organisations, and also with our district health boards, or those in hospitals, nurses and doctors. So we do a wide range of, like I said, government and non-government organisations around New Zealand. There's just a few of the course outcomes there. Obviously, we want to increase their knowledge and skill and a greater appreciation of nutrition and physical activity from a Pacific perspective. Implement personal changes, and also those changes hopefully will reflect in their families. And I won't bore you by reading through all of those, but those are some of the key outcomes of the courses that we run. So, like I said, part of mine is promotion and recruitment of our courses. Some of the key ways that we do it is through our website, heartfoundation.org.nz, and there's a tab there for courses. Also on Facebook. On Facebook, we try and do a lot of course promotion, and we do offer tips about nutrition, physical activity, and whatever else is topical with our Pasifika community around food, nutrition, and physical activity. Also, we are on air on radio. We do have 2 slots per month on radio, and it's broadcasted from Auckland, but it has a national reach. And we do have little adverts that we run on 2 radio stations, and also through our email database, I think, and word of mouth. mouth, sorry. Some of the other key services that Pacific Heartbeat offer is, like I've mentioned, our online presence through social media platforms, Facebook, and obviously through our website, the radio, and we do develop resources ourselves. The other key thing that we've done is church engagements. We do engage because the thing is, if you want to find where our Pasifika people are, 9 times out of 10, church is where they are. So we do run courses for our communities in the church settings. And also we do offer advice. We receive inquiries in regards to food and nutrition for our Pacific families and individuals. And that's a wrap from me. Thank you very much. And now I will pass the rugby ball on to the lovely Maria Bernard. Over to you, Maria.
Thank you, Leo. Malo lava. I'll share my screen.
Welcome, Maria. Great.
Thank you. Can you all see that?
Can indeed.
All right, talofa lava, and warm Pacific greetings from here down in New Zealand to all of you, mostly in Europe, I guess. So my name is Maria Bernard. Not a very Pacific sounding name, but it's because my great grandfather was French. So I don't know what he was doing in Samoa. But I'm New Zealand born Samoan. One of the Pacific Heartbeat nutrition training facilitators. And I'm also an associate registered nutritionist. So I'm just going to cover 2 of the courses that I facilitate, which is the community nutrition course and the cooking course. So we'll just get straight into it. Okay, so the community nutrition course has these are some of the main outcomes, so that our participants have increased knowledge and skills about nutrition and physical activity from a Pacific perspective, but also that they have a deeper appreciation of the value of nutrition in contributing to improving their health and Pacific health. But one things that we want our participants to go away with is that they will share what we've shared with them on the course. They will share them with their families, and also their communities and church groups, and just be a good role model from what we've taught them on the course. The course is $20 per person. So we facilitate it over 1 day, which covers about 4 hours, or can be over 2 days, 2 hours each day. These courses target community and church groups, as well as the early learning centers, especially the High Pacific early learning centers. And it's delivered in a local community setting. So no prior knowledge of nutrition is needed. These are basic nutrition courses, but obviously a little bit of adequate English is required. So these are some of the topics that we cover on the course. And so the 4 food groups, we also cover healthy food choices, including the good fats and the bad fats, and the impact on heart health. We also cover food label reading at the supermarket, which is, really empowering once they can learn how to read these labels. And also sugar in drinks, and just measuring how much sugar is actually in those sweet drinks. So we do face-to-face community nutrition courses delivered by Pacific facilitators generally, and for the Pacific communities. So by Pacific, for Pacific. And it has been delivered in Samoan and Tongan languages. So one of our facilitators, Takui, she is Tongan. And so just our engagement style, so especially for CNCs, we use simple language and terminology. We really try to make the activities fun and interactive, and use those activities to engage participants and help them to retain the information. Because we found that Pacific receive information more effectively if it's kinesthetic and visually given to them through those resources. So I'm just going to show you some examples of the activities that we do on the courses. So just an example of the sugar activity that we do with our participants. So it's just how to measure how much sugar is actually like a bottle of Fanta, for example. So the highlighted in red is what we show to the participants where they need to be looking on the label. And the next slide is just the really step-by-step process of how to work out how much sugar is in this bottle. In this particular bottle there, we find out that there's 15 teaspoons of sugar in the bottle, which a lot of participants are really shocked at when they find out how much sugar is actually in the bottle. And it actually leads a lot of them to reduce their amount of sugar or even just start drinking water, which is great. This is a picture of one of the early learning centres that we were delivering at. It's a Pacific Early Learning Centre, and they're actually doing a label reading activity there. So really hands-on activities. So online, for COVID, we moved to online courses at the beginning of last year. So the positive things about moving online is, as Leo said, we have a much wider reach outside of the Auckland area. Auckland has got the highest amount of Pacific population in New Zealand, but we were able to reach people in the south of the South Island, these cities like Timaru and Oamaru, but we also managed to reach our Pacific neighbours internationally. Tonga, we had some girls join us from Tonga, and also Vanuatu and Samoa, which was amazing. So participants also were able, another positive thing is that they can tune in from the comfort of their own homes or from their offices, which was great. Online, we created this friendly talanoa. So talanoa means like chatting in Samoan. And we did this at the start of our online courses just to relax our participants and just make them feel more comfortable. So the kind of negative things about online is that you can't beat face-to-face. So face-to-face is the best possible scenario for health promotion. And it has you can't beat the atmosphere that you create and the interactivity, and it's hard to read the body and language cues when you're online. Okay, so moving on to the cooking course. So it was really designed in response to as Collin was saying, the negative statistics of Pacific people in New Zealand. However, we also did an online and a needs assessment within the Pacific community about what they thought about having this kind of cooking course for our Pacific community. And we found that people were just overwhelmingly said yes, and said this has been something really beneficial for our community. And that's why we started it. So the course imparts like a hands-on nutritional knowledge and offers practical cooking skills, things like trimming the fat, draining the fat, and even chopping skills. We teach that. So the courses offers face-to-face and online. We recently went online, so this is a very new course offered. We've only done about 3 courses so far, so 2 online and 2 face-to-face, sorry, and 1 online. And it's a free course offered to the community. So it's face-to-face and online, about 4 to 5 weeks. Online is a little bit shorter than face-to-face. So the objectives are that, really we want to make our Pacific audience that come really confident to cook healthy meals at home. And by doing that, hopefully they would buy less takeaways. And all the recipes that we teach on the course, they are all, most importantly, affordable and easy and quick, healthy meals to cook. So the affordability really resonates with our community. As Collin was saying, a lot of them are in the more kind of lower socioeconomic groups, and cost is really important to them. So participants also, we would like them to share their knowledge with their families and take all that knowledge home and with the wider community. But one thing we really encourage them to do, so all our recipes have lots of colourful vegetables in them and the leafy green vegetables, really to encourage them to eat more vegetables in their diet, because they're very good at eating meat and starchy vegetables, but not the colourful, nice leafy green ones. So these are just a couple of quotes from people who have finished the course and been on the course. So I'll just read the first one. So my family thoroughly enjoyed the meals last night. My children, especially my girls, will definitely cook the mini pizzas again. Really appreciate having short courses like this that will help many families, including mine. The second quote at the end, they also say that it was very, very important for them to have these meals that are very cheap, affordable for families. So we did have some challenges on both the CNC and the cooking course. So there are challenges promoting and recruiting participants, and also students' commitment and attendance to the course. So sometimes on the cooking course, we have people attending 2 sessions and then we don't see them again. And for the CNC, we have, especially if it's over 2 days, some people might attend the first course and then not the second course. So this is a bit of a challenge. Going online, our participants need to have access to internet, and then they need to have the skills to use their phone or a laptop to be on those online courses. For the community nutrition courses, some of our applicants have English is not their first language, so we need to be mindful of that. And also they may have not finished high school, so we also need to be, make the language simple, and just the interactivity of the activities are quite hands-on, so they can get involved with the activities. With the CNCs, we always invite the parents to come along, because obviously they are the ones that do the shopping at home and things like that. So, but there is quite often a poor parent uptake in the involvement with the CNC courses, unfortunately. With the online courses, we have, with all our courses, we have evaluation and feedback forms. But when we take it online, we find it hard to get the participants to send back. It's a bit of a challenge for them to send back the forms, but we're working on solving that by putting it on Microsoft Forms, so it's a lot more user-friendly, and hopefully that's going to solve the problem. There's also individual challenges. So this first one says, the biggest challenge is putting the learnings into practice on a regular basis and making it a habit. So there's a theme of this change. Some families are resistant to the change, but it really is a step-by-step change, and it takes time to change these habits. And yeah, so that I think a lot of our participants have seen that through the courses. So that's it from me. I'll just stop sharing my screen. Thank you.
Thank you, all 3 of you. I've some questions to start with. My colleagues like either to put comments in the chat or put up a hand. I'm sure there are others as well. I'm conscious the light's fading here, which is a sign of bad weather rather than the coming of the evening. I'll put my light on in a minute. So a lot of what you said really resonated with us. We at C3 and some of our colleagues online are involved in a significant project across Europe, in England and France, looking particularly at things like vegetables, better physical activity, better diet. And your comments about colourful vegetables certainly resonate with us. I wondered whether growing vegetables was any part of the work that you were doing, was one of my questions. And the second one, quite different, because the challenges of the pandemic have given us in C3 with our community engagement programme, whether digital access was an issue for some of your participants, or whether that's a universal ability and access is not an issue. So two questions really, one about digital access and one about whether growing as well as cooking was part of your programme and thinking. So my questions, and then I see others are beginning to come. I'll leave the three of you to decide who answers, and don't all speak at once, I guess.
I can take the one about encouraging people to cook at home. I think a lot of the early childhood centres do have gardeners going in to encourage them to cook, to grow vegetables at the early childhood centres, and teaching children, and they do cook from the garden, so that's quite a big thing. And I think it was actually our last cooking course, which we had to take online in the end. We actually invited a gardener to come and be a guest speaker, which was cancelled. So we are trying to encourage our Pacific audience to start growing at home. Yeah, so that's a really good point.
Great, thanks, Maria. And is it Leo or Collin who's going to talk about digital access? Great, Leo.
I was just going to add also a number of churches that we've dealt with are also making a big drive in terms of gardens at home. So that's one thing that a lot of some of the churches have moved to, is really doing gardens at home, and a lot of them having competitions to see who can grow the most, and displaying it through the internet is probably the one thing. A lot of them put them on show through internet, and a lot of the churches, what I've seen is a lot of them are moving to digital, especially through Facebook. So that's one medium that a lot of the churches get to display their wares and tears and food. Thank you.
Great. So I have a question from Natalie, who's one of our colleagues working with our French programme. Over to you, Natalie.
Hi, thank you very much. I thought it was very, very interesting. So I'm a nutritionist for C3, and I work on the community program in the north of France, for Aspire and C3. So it's a program reaching the disadvantaged community. So I can really understand what you meant. So I had a first question about more global question. You said that the rate in childhood obesity has slowed a little bit, but not in the most disadvantaged. So was it connected to any government policy or anything?
These are off of, we have a thing here. Before you go to school in New Zealand, you're supposed to get what's called a before school check. You get your eyes checked, you get your hearing checked, and your weight taken, and so on. So this is off of routinely collected data from what's called the before school check. So it's off a big data set. Is it because of a policy? We have a yo-yo approach with school food. And we had a government, the one before, had a policy of healthy eating, healthy actions, and supporting healthy options at the school and all of that sort of stuff. So the next lot came in and threw that all out, and we went back to where we were before that. And so it's, two steps forwards and three back kind of thing. So I can't say that it was directly connected to a policy. We've flirted with policies over the years, but they're not sustained. It depends on the color of your government, in a sense. the Nats, as we call them, the National Party, tend to be great believers of the free market, and they don't like any kind of limitations or restrictions. When we have a social government, a Labour government, they tend to be much more sympathetic. So I can't, if you pushed me and you say, Colin, was it due to a policy? I can't say that it was, but there's general awareness in New Zealand about childhood, about school lunches, about what children get to eat and so on. But it's not directly due to any one policy. I should point out, again, I'm a bit obsessed with inequities in New Zealand. The loss, the reduction in prevalence of childhood obesity, children under 4, didn't happen in low income areas, which is where most of our people will be. So that's why I'm not jumping out and down and getting excited that we finally got on top of childhood obesity, because it's selective. And as you know, it's pretty much the well-to-do with all of the means and the resources to choose healthy options are going to benefit from this. The rest of the population, like the communities we deal with, less likely to do so. Nonetheless, I think it's an encouraging trend because, as you know, Natalie, it's not something that we are seeing anywhere else in the world. I don't know about France, but childhood obesity problems globally continue to rise, and it's not dropping. And this experience in New Zealand is one of the few instances that I'm aware of.
Thank you very much.
Thanks. I'm going to ask Katie Cooper to ask her question, and followed with Antonia Bunnin. And I'm conscious of the time, so question and answer will have to be snappy. Katie, over to you.
Thank you. I'm interested in the sort of the broader impacts of COVID on your community. So you talked a little bit about the pivot online, but can you talk a bit more about the health, the effect of health on health of the lockdown, for example? Are you sort of using messaging around COVID? Are you working this into what you're doing?
So I work a lot with the government on messages about COVID, and there's someone earlier was talking about Zoom fatigue. I can tell you that over a year on with information for the communities, most of these have been online, and so it's a lot of this, and and it's done in different languages. We didn't go into the details. Leo referred to it. There's several different Pacific communities. We all get put together as one group, but in fact there's Samoans and Tongans and Niueans and Fijians, and we have to do these community sessions about COVID, what to do to protect themselves, about social distancing, about wearing masks, and it's all done in the different languages. And let me say, we're getting quite good at it because we've done so many of them. The not so good news about impact of COVID is that Pacific people and indigenous Maori, as you can imagine, business is slowing down. We don't get as many English people visiting us. And so there's been a number of people who've lost their jobs. Unfortunately, more women than men have, and Pacific and Maori folk tend to be the ones that are in the hospitality industry, and they're often the ones that are first impacted. So we've had families that have been negatively impacted and have had to rely on food parcels and stuff like that to keep going. Unfortunately, those food items tend to be highly processed, biscuits and bread and rice and flour and all of that sort of carry on. So it's a mixed picture, if you like. The Pacific communities have responded really, really well to the threats of COVID and contained a big cluster here in this town in August of last year. The churches came together, the Pacific media came together, the community leaders came together, and everyone worked really well together and contained it. But as I say, the downside is, negative impact on jobs, on income, on food, children getting restless, being locked down at home and affecting their school. So not enough time to talk properly in detail, but I hope you get the kind of impression of the impacts that it's had on our communities here.
Indeed.
Yes,
I'm going to ask Antonia and Michaela to throw their very different questions at you because I'm very conscious of the time. So Antonia's, which is short and probably easy to answer. Michaela's you might want to pass, but let's hear the question anyway. Over to you, Antonia.
So I'm just interested in whether you find any gender imbalance in the degree of sort of interest and engagement from that you receive, and whether, I mean, looking at the range of cookery courses, I wonder whether you get more interest from women and whether you've got any activities that are specifically aimed at men.
Yeah, so we eat all the food and the women do the cooking. No, ignore that. It's trying to be funny.
Some of us recognize that though.
Maria, it's probably one for you.
Yes, I mean, generally we do get more women, and I think Leo's done a course, and I think the course that he did, there was a fair amount of men, and the last face-to-face course, we actually had about 4 men who are really interested in cooking, and one of them was a minister, so he had a really big reach that he could share those skills with. But we don't give them different activities because it's all the same recipe, and we just get them to everyone does a dish equally. So we usually get them to pair up because it's much easier, especially if you're not confident. It's good to have a buddy to start cooking with and prepare something with, and to gain your confidence. But I hope that answered your question.
Thanks. Michaela, your question sounds more challenging. Over to you, and then we'll need to wind up.
Lovely, thank you. So really interesting session this morning, really enjoyed it, thank you. I want to hook back right to the very beginning where I heard that the rates of ischemic heart disease deaths is going down, and that is always wonderful to hear. Now in the UK, as we see our heart disease deaths going down, it means that we tend to are surviving those heart attacks. It's not necessarily that we're having less of them, and we know the population is way more unhealthy than we ever were. So what we're starting to see is real increases in dementia, Alzheimer's, because people are living longer, and the risk factors remain there. And I just wondered if there's been a nod towards the future, and have you started to see a shift or change yet in your death rates or incidence of dementia and Alzheimer's? Certainly it's really on the increase for women at the moment. So just a nod to the future for you.
Yes, of course. Funnily enough, just last night I was with colleagues talking about this issue, mental health more broadly and mental disorders, and how little we know. And one of the issues that came up was dementia in Pacific communities. And it's anecdotally, there appears to be an increase, but it's anecdotes. We don't have good, reliable data. One of the things about Pacific people is they tend to protect their own within their families and within their communities. And if you look at figures from institutions and service utilization, you wouldn't have a clue where things are, because an older person, a grandma, a grandfather with dementia would be cared for within the family, and no one would know. It takes a lot for Pacific families to ask for help. So we don't know is the short answer. And the conversation last night was, I was trying to convince a funder that we needed to do a proper survey, a proper study of dementia in Pacific communities, in the various communities that you've heard us speak about, Samoans, Tongans, and so on, because, frankly and truthfully, we don't know. We think it's increasing, as you point out, which is not unexpected given your experience and elsewhere in the world. So we expect similar things, but we just don't know. And as I say, it's a little bit more difficult for us because we have the way culturally you're supposed to look after your old people as best you can, and that's the deal, that's the contract. And it does mean, of course, we has unreliable information, like other things outside of dementia. So hopefully, if we have this session in a year's time, I can tell you with some confidence what has happened. So but it's of active interest to us here in New Zealand. The general view is that it's uncommon. If you talk to people, they'll say it's uncommon. I think the truth is we don't know.
Yeah, it's an interesting point, Colin, because you're talking about dementia. In my church, we have quite a few people that are in their late 70s and 80s. And one thing I've noticed is quite a few of them, you know, talking to their siblings, a lot of them are actually, a few of them are showing signs of dementia. So I was like, oh, well, and there's quite a few of them. Majority of them are Samoans, you know, and I was saying, okay, you know. So yeah, I think it'll be very interesting to do a study, especially with our elderly that, you know, because it's, you know, for me, it's you know, I'm not too sure how widespread dementia in our elderly is.
What you will find,
thank you,
in the UK, is
Michaela, I'm conscious of, I'm really over time and we normally are very careful here, but it has been so fascinating. It's been good to let the conversation go on. Leo said, I have a number of quotes from all of you, but Leo said early on, nothing beats face-to-face. And I'm sure he's right, but we wouldn't have had this fascinating session were we not online. And because I can't imagine the three of you just popping over for an hour's breakfast in central London, much as we'd like to see you all and hope that one day we will. But thank you for a really
Christine, I'm told by our leaders that we are about to open a bubble with the UK. So I'm always keen to hop on a plane if you want to send us a ticket.
Brilliant.
Times two.
Yeah, we're very much looking forward to meeting you in person, to seeing you here. But in the meantime, that's been a fascinating session. Thank you very much. We've lots of similarities, but also ideas that relate to Europe. And I see my French colleague nodding as well as the English colleague. So thank the three of you very much indeed. And we look forward to meeting you somehow again, and maybe you joining some of certainly our breakfast seminars online. Thanks very much, everybody, and thank you to our audience.
Thank you very much for the opportunity. God bless.
Bye.
Okay.
Thank you.
Thanks, Leo and Maria. Thank you.
Thank you, Colin.
Thanks, bye, Antonia.